Good morning. I'm Bonnie Norrick, the subject matter expert for CAUTI, and we're going to get going with that. I know I'm between you and lunch, but please stay with me for the next hour, and we will discuss the UTI protocol for 2019. We will also look at fever, age, and device association, collection data forms and table of instructions, summary data and device day count, key concepts and pitfalls, and apply the UTI protocol with some case studies. The burden of UTI. That's the reason why you're here. But first, I'd like to thank you for all that you're doing to prevent infections. After some early lack of progress, there have been steady declines in CAUTI over the past few years. The gains have been most marked in non-ICU locations, but recent years we've seen progress in ICU as well. Even with the removal of yeast as a pathogen from the urinary site, we are still seeing decreases in CAUTI. In fact, from 2014 to 2017, we had a 5% decrease in UTI. Give yourself a hand. The average cost of a CAUTI in the hospital can be anywhere between $5,000 and $14,000 per admission, dependent on the drug being used and the length of stay. And UTI continues to be ranked number 4 HAI in the United States. This is the website link for the UTI surveillance page. Most of the material we discussed today can be found here. We will visit a few of these sections today, but I strongly recommend that you set aside some time when you get back to work. 15 minutes. Close the door to your office, put the phone on silence, get your favorite beverage, and stress snack. While enjoying some decompression time, pull up the website page and open each heading and take note of its contents. Taking some notes as you know where to look the next time you need the information. Definitely take a look at the CMS supporting materials and do this for the webpage for the surveillance you are performing at your surveillance or at your facility. So now we'll look at some updates. There have been no changes to the protocol definitions, but we have added some language for clarification and enhancement for understanding. Greater than 2 calendar days has been replaced with more than 2 consecutive days in an inpatient location. Under SUTI 1A, catheter-associated urinary tract infection in any age patient has been clarified. Under this statement, patient has at least one of the following signs or symptoms. We have a reminder here for fever. To use fever in a patient greater than 65 years of age, the IUC needs to be in place for more than 2 consecutive days in an inpatient location on the date of event and is either still in place or was removed the day before the DOE. The remainder of the definition is unchanged. Comments have been added to UTI and ABUTI criteria. The following excluded organisms cannot be used to meet the UTI definition. Any Candida species as well as the report of yeast that is not otherwise specified. Also, catheter, Foley catheter, and urinary catheter have been replaced with indwelling urinary catheter, or IUC, throughout the protocol. For the next few minutes, we will review Chapter 2, Identifying Healthcare-Associated Infections in NHSN, for the definitions as they relate to UTI. Until you become familiar with these rules, you will be working with both Chapter 2 and Chapter 7 in your hand, side by side. Also note, and I will repeat this throughout the next hour, that NHSN primary site of infection is your UTI. Use your sending cases for reviewing to call UTI secondary to another site. You cannot. UTI is a primary site of infection. So let's review the IWP, the DOE, and the RIT. The UTI for the infection prevention of the infection window period is always set by the first positive urine that is used to meet the definition. The IWP is not set by UTI signs or symptoms. This slide illustrates elements that fall outside the IWP period, cannot be used in the determination. Elements are defined as urine culture and your UTI signs and symptoms, or a matching blood sample. The DOE is the date of the first element used to meet the NHSN site-specific infection criterion occurring the first time during the 7-day infection window period. Keep in mind that the DOE could be the urine culture or the signs and symptoms, whichever comes first. The RIT applies to both POA and HAI determinations. The date of the event is day 1 of the 14-day RIT. If criteria for the same type of infection are met and the date of event is within 14 days of the RIT, a new event is not identified or reported. Additional pathogens, specifically a bacterium that's greater than 100,000, recovered during the RIT from the same type of infection, are added to the event. Note the original date of the event is maintained in the original 14-day RIT. Device association determination and the location of attribution are not to be amended. In any UTI criterion sets an RIT and an SBAP, including the POA events and non-catheter-associated events. Okay, that's the basic Chapter 2, definitions as they apply to UTI. Now let's look at Chapter 7, UTI concepts and definitions. This is the NHSN definition of an indwelling urinary catheter, specifically inserted into a urinary bladder, including a neobladder, through the urethra and left in place. For a bit of trivia, Foley was named for Frederick Foley. He was the surgeon who first designed the urinary catheter. A word about neobladder, because we've had several questions about this. In effect, these devices become the urinary bladder for the patient, and therefore, if a urinary catheter is inserted through the urethra and into one of these bladders, it is included in the CAUTI surveillance. The neobladder is made from a piece of a person's own small intestine, which is formed into a pouch and positioned inside the body in the same position as the original bladder. With this procedure, most patients can void normally. There is some concern for intestinal flora colonizing the bladder. NHSN definitions currently account for contamination of urine specimens. Remember that to remove such cases from CAUTI surveillance would require the IP to identify which patients with these catheters had these type of devices and to remove all associated catheter days from the summary data. This would be pretty labor intensive. A specimen with a culture result of no more than 2 organisms is excluded for use in meeting a UTI definition. A urine sample collection should only be collected when there are apparent signs and symptoms correlating to a UTI. These are not indwelling urinary catheters: a straight cath, a condom cath or a Texas catheter, and in and out caths. A suprapubic catheter does not count as a catheter unless there is a catheter inserted into the urethra. The following also do not apply: a nephrostomy, a urostomy, an ileoconduit, and a perineal urostomy. A urine from any of these sites should be used in the determination of a UTI. Let's talk about urine cultures for a brief minute. If you have not visited your microbiology department at your facility, I recommend that you do so when you get back home. The microsupervisor can be your best friend and the most helpful on your IC committee. Get a tour. Watch a urine culture being plated. A urine sample is placed on a blood auger plate and a selective media plate for gram-negative organism growth. The microbiologist uses a calibrated inoculating loop to streak across the plate through the middle and then perpendicular streaks across the first. This is one method for plating. There are others. After 18 to 24 hours of incubation, the microbiologist will count the numbers of colonies on the plate. One colony on the Petri plate represents one viable cell, or one colony forming unit. For example, if you use 1/1000th of a mil that's plated, the colony count must be multiplied by 1,000. If the microbiologist sees 10 colonies, that's 10,000 colony forming units per mil. Now back to interpreting our culture. Excluded organisms. Candida species or yeast, not otherwise specified, mold, dimorphic fungi, or parasites are excluded as organisms in the UTI definition. Therefore, blood with these organisms cannot be used secondary to UTI. Excluded organisms may be present in the urine. A urine culture with yeast can be used as long as there is at least one bacterium greater than 100,000 or equal to, and no more than 2 organisms. For example, greater than 100,000 mils of E. coli and greater than 100,000 colonies of C. albicans is an acceptable culture result that you can use as an element. For usable culture or unusable culture results, you have to have, remember, no more than 2. So you may have, for example, contaminated cultures that are not used for UTI surveillance. For example, greater than 100,000 E. coli, Staph aureus, C. albicans. That's 3 organisms, but you only got one number there, right? So just remember, only two, just like Noah. Urine cultures including mixed flora or equivalents such as perineal flora, vaginal flora, and normal flora cannot be used. And if you're wondering what flora is, the bacteria and other microorganisms that normally inhabit a bodily organ or part. So, for example, if you should see a culture that says greater than 100,000 mils of E. coli with perineal flora, it is not an acceptable culture. Some other clarifications. If you see 75,000 to 100,000 mils, this is not an acceptable culture. Is it 65 or is it 99,000? Or is it greater than 100,000? You don't know. Organisms of the same genus with different species are 2 organisms. Example here, Pseudomonas aeruginosa and Pseudomonas fluorescens. The same organism with different micro susceptibilities is one organism, such as MRSA, methicillin-resistant Staph aureus, is the same as MSSA as far as counting it as one organism. The IWP is set on the urine collection date, not the result date. Do not add multiple urine cultures together. For example, on March 1st, you have a culture result of 2 organisms. On March 2nd, you have a culture result with 1 organism. Do not add those to exclude those cultures to be greater than 2 organisms. We get the question, I'm sorry. Use urine collection from any body location. For example, as I said earlier, nephrostomy or a suprapubic catheter. You got urine, you can use it. So let's put it all together. There are 2 specific types of UTIs. You have symptomatic and asymptomatic. Both types, if catheter-associated, must be reported as part of any CMS CAUTI reporting requirements. So now we're going to go through our protocols here one by one. For a SUTI 1A, the catheter-associated urinary tract infection, the patient must meet 1, 2, and 3 below. The patient had an indwelling catheter that had been in place for more than 2 consecutive days in an inpatient location on the date of event and was either present for a portion of the calendar day on the date of event or removed the day before the day of event. Here's that reminder statement I talked to you before. To use fever in a patient greater than 65 years of age, the IUC needs to be in place for more than 2 consecutive days in an inpatient location on the date of event. It would be impossible to determine, let's back up. Because a fever is non-specific sign of infection, it is possible that an individual may run a fever due to more than one infection at a time. It would be impossible to determine which infection, if not both, was the cause of the fever. If a fever is present, it must be used in the UTI definition. This process neglects the use of clinical subjective decision-making to determine the NHSN HAI events. Hence, there's no asterisk, as you can see here, for temperature. If you've got one, you've got to use it. With no other recognized cause is addressed in frequently asked question number 14. To use no other recognized cause, it should be clear that the symptom relates to the other cause and is clearly differentiated from a UTI symptom. And that's for suprapubic tenderness and for costovertebral angle pain or tenderness. These symptoms cannot be used when the catheter is in place: urinary frequency, urgency, or dysuria. Once that catheter is removed, you can use those symptoms. And then the third, the patient has a urine culture with no more than 2 species of organisms identified. At least one must be a bacterium greater than or equal to 100,000. And remember, all the elements of the UTI must occur during the IWP. So, knowledge check, get your phones out. On March 25th, the patient was admitted to acute care hospital for trauma. A Foley was inserted. The catheter was in place from 26th to the 27th. On the 28th, that catheter was removed early in the morning. At noon, there was a complaint of urinary frequency. There was no fever on the 29th. There were elevated WBCs on the 30th. And on the 31st, we have a positive culture of E. coli. True or false? The patients complained of urinary frequency on 3/28 after the Foley was removed can be used to meet SUTI. So, we need music, guys, next time. So, And the answer is true. So let's look at the rationale here. The 331 positive urine culture sets your IWP from 328 to 4.3. On 328, urinary frequency is the first element to occur within the IWP. Therefore, it is the date of event. The catheter was in place for greater than 2 days on the date of event, so you have a CAUTI HAI. So let's talk about when you go to report this. You're going to select risk factors for that urinary catheter. You're going to check one of the following, because there's 2 choices here. In place, if the urinary catheter has been in place for more than 2 consecutive days at an inpatient location and was present for any portion of the calendar day on the date of event. Or you could select removed if the urinary catheter had been in place for more than 2 consecutive days in an inpatient location and was removed the day before the event. In this case, we have in place. With urinary frequency, urgency, or dysuria is selected. As we see here, frequency is selected. A pop-up will alert you as a reminder that you have selected a symptom not usable if the IUC was in place. This is not a hard stop. You may want to keep this slide for future reference. So now we're going to look at SUTI 1B, non-catheter-associated urinary tract infection of any age. The patient must meet 1, 2, and 3 below. For 1, the patient has an indwelling catheter, but it has not been in place for more than 2 consecutive days in an inpatient location on the date of event. The patient did not have a urinary catheter in place on the date of event, nor on the day before the date of events. The patient has at least one of these signs or symptoms. So there's that fever again. So let's talk again about that fever. In older adults, specifically non-catheterized patients who have a fever with no other localized signs for UTI, There is a cause other than UTI in 90% of the cases. Therefore, we have this age limit on fever in SUTI 1B. If you have a fever, that patient needs to be less than or equal to 65 years of age. Suprapubic tenderness and costovertebral angle pain. There has to be no other cause, as we discussed before. And your urinary frequency, urgency, and dysuria. These symptoms cannot be in place. Of course, you wouldn't have these symptoms, or you could use these symptoms because the catheter wasn't present, right? So the patient has a urine culture also with no more than 2 species of organisms identified, at least one of which is a bacterium greater than or equal to 100,000. And again, all these elements have to be within the UTI criterion IWP. Knowledge check again. Get those phones back out. This patient is 47 on June 11th with a fever of 101.7. History of Pseudomonas aeruginosa in a wound on the previous month. On 6/13, we have a quick cath done for 50,000, and it was a pseudo aeruginosa at 50,000 and 100,000 for C. albicans, no fever. On 6/15, patient spikes a fever, 101.3, and the urine is collected via quick cath again, and the result is greater than 100,000 Pseudomonas and greater than 100,000 C. albicans. Which urine culture will be used to set the IWP, 6/13 or 6/15? And there you go. Do, 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 do. And the answer is 6/15. Very good job. Good job. So let's look at the rationale on this one. The 6/13 urine culture is not eligible due to the bacterium count that's less than 100,000. The 6/15 urine culture sets the IWP from 6/12 to 6/18. The 6/11 fever on admission cannot be used because it did not fall in the IWP of the 6/15 positive urine culture. The 6/15 fever is in the IWP, and it's an acceptable element. Remember, the patient is less than 65 years of age. To meet SUTI, the DOE is 6/15. There's no catheter in place on the DOE nor the day before. So this meets SUTI 1B, non-catheter associated UTI, and it sets our RIT and our SBAP. Now we're going to look at SUTI 2, which is a CAUTI or a non-CAUTI in a patient that's 1 year of age or less, and the patient must meet 1, 2, and 3. The patient is less than 1 year of age with or without an indwelling urinary catheter. The patient has at least one of the following signs or symptoms. Patient has a fever, and then hypothermia, apnea, bradycardia, lethargy, and vomiting are all significant signs for our baby here that's 1 year or less. So that's why I've had them a different color here. No other recognized cause goes with apnea, bradycardia, lethargy, and vomiting, because our little ones can have other things going on with them. And then suprapubic tenderness, of course. The patient has a urine culture that has no more than 2 specimens of organisms, one of which is a bacterium equal to or greater than 100,000. So we will go through a little case here, and remember, all elements of the UTI criterion must be within the IWP. So we have a 2-month-old admitted for diarrhea. A catheter is inserted, and the patient vomits twice, and the urine culture grew out greater than 100,000 of E. coli. This meets our SUTI 2, and remember that it can be used non-CAUTI or CAUTI. Let's look at a booty now, and this goes for any age, and the patient must meet 1, 2, and 3 below. A patient with or without an indwelling urinary catheter has no signs or symptoms of SUTI 1 or SUTI 2 according to age. Now remember, Your patients greater than 65 years of age with a non-catheter-associated ABUTI may have a fever and still meet the ABUTI criterion. Patient has a urine culture with no more than 2 species of organisms, one of which is a bacterium that's equal to or greater than 100,000. And the patient has an organism identified from blood specimen with at least one matching bacterium to the bacterium identified in the urine specimen, or meets LCBI criterion 2 without a fever and matching common commensals in the urine. And we will come back to this again as a case study. And remember, all elements have to be in the IWP. Catheter-associated ABUTIs, if reported, if their CAUTI is selected in your monthly reported plan for this location, remember, if you're reporting to CMS, if it's catheter-associated, you got to report it. So here we go with the case. Patient was admitted for an MI. The catheter was inserted on the 20th. 21st through the 23rd, there are no signs or symptoms. February 24th, we have elevated WBCs, no UTI symptoms. We do have a positive blood with Staph aureus and a positive urine culture greater than 100,000 of Staph aureus. From the 25th through the 27th, no signs. And on February 28th, we were allowed to go home, and that Foley was removed. So let's look at the rationale here. The 224 urine sets our IWP 21 through the 27th. There are no symptoms. However, we do have a matching blood organism within the IWP. We meet that ABUTI with a DOE on 224. The urinary catheter was in place greater than 2 days on the date of event. Therefore, this is a CAUTI with matching blood organism, and it is secondary. The catheter-associated ABUTI is reportable. I told you you're going to hear this a lot, didn't I? In the location of the facility reporting plan. Data collection forms and table of instructions. We're going to go through those. This is where you would go to get your forms. The data collection form and the table of instructions are found on this page. As I have selected here, we're going to open that up and have a look at the very first 2 documents that are there, the event form and the TOI form. When you select the event form, there are 2 possibilities. You can get a PDF or you can get a Word document. If you're new to IP, you'd probably want to print out that PDF and keep track of all your notes on that PDF. If you're real experienced, you know this by heart, right? You probably don't print it out. But when you start training some new folks, or when you start talking to your nurses, print it out and talk to them about what you do. There's also that Word document. If you're trying to track, say, an outbreak, that would be very helpful if you needed some extra fields in there to swap some out that you can edit that are not mandatory edits or mandatory fields, and use those to pull any reports if you're trying to select something for an outbreak. So that's another way that you can use your Word document. And here's a blow up of that. Remember, anything that's asterisks, you have to gather that data and put it into NHSN. This is the end of that document. This is actually page 3 of 4. Examine the result codes a little bit closer here in case you haven't examined those. Some of you I know have got electronic surveillance and you may not see this page black and white in a Word document or PDF. So let's look at these codes a little bit closer. Your microbiology labs may not do all the drugs that we have listed in NHSN. So if they don't test it, go ahead and put that in there. Don't freak out and say, oh my gosh, we didn't test this. It's okay. Just put not tested. And of course, you know S is susceptible, I is intermediate. NS, what is NS? The non-susceptible is another way the microbiologist can say, we don't know if the drug is resistant, but we do know that it's not sensitive to that particular drug. And the SDD is susceptible dose dependent. Susceptibility of the isolate, it depends on the dosing that's needed. You may need more dosing more frequently for that particular drug. This is not in your handout. but I wanted to get it in front of you just to talk real quickly for any of those who are real new and haven't had to put in a sensitivity yet. Each one of these major blocks here is a class of drugs. So let's take a look over here at this group where we got Cipro, Levro, and moxicillin. Note that we had 2 drugs reported, but moxicillin is not selected. As long as you get 1 drug listed in here with a result, you're good to go. You don't have to have this other one with any kind of not tested or any kind of marking. Colistin and polymyxin B, this facility did not do either, and they just marked 1 box as not tested. And then, of course, we just had 1 drug here, Cefer, wasn't tested at all. So I just wanted to get this in front of you in case you hadn't analyzed that before. And at the bottom of this screen is where you would find description of alerts for unusual sensitivities. It's a nice little document. If you haven't opened it up before during those 15 minutes I talked about earlier in the presentation, take a look at this document. This is your TOI instruction form. It's very, very useful. It explains every field that's on the document for the urine event form, and you'd be surprised what you might learn there if you would print it out and read every field. So take a look at that one. Now, we've already talked about in place for the risk factors and removed. The third one we didn't talk about is neither. When you go in and pick a risk factor, that's for UCI. But there's 2 other fields here I wanted to talk about. Again, if you're looking at outbreak situation or you've got an uptick in your CAUTIs, maybe you want to start documenting the location that CAUTI or that catheter was inserted, as well as the date. So make use of those if you're in that situation. So now we're going to look at denominator and summary data. Denominator data, patient days and device days, should be collected at the same time every day for each location performing surveillance to ensure that the differing collection methods don't inadvertently result in device days being greater than patient days. And you've heard about that from the previous 2 speakers. Once the month is completed, go to the Summary Data tab and add the patient safety data by location. Don't forget to select Report No Events box if you had no events for that month. Data sampling can also be collected electronically or weekly sampling, and we talked about that, but we will talk about it again. Electronically collected data, validate the electronic method against the manual method. That's our gold standard. Collect 3 months of concurrent data using both methods, and then calculate the data to be within 5% plus or minus of the manually collected. Weekly sampling reduces staff time collecting surveillance data. A once-week sampling of denominator data to generate estimated urinary catheter days may be used as an alternative to daily collection in non-oncology ICUs and wards. To ensure the accuracy of estimated denominator data is obtained by sampling, only ICU and ward locations with the average of 75 or more urinary catheter days per month are eligible to use this method. Sampling may not be used in specialty care areas, oncology locations, or NICUs. Evaluations of this method have recently shown the use of Saturday or Sunday generate the least accurate results of estimating the denominator data. Therefore, these days should not be selected for sampling. When these data are entered, the NHS application will calculate the estimate of the urinary catheter days. If the day designated for the collection of the sample day is missed, collect the day on the next available day instead. Pitfalls. Common misapplication pitfalls. Calling UTI secondary infection, positive urine on admission automatically being counted as POA, and UTI signs or symptoms such as fever on admission automatically called as POA. UTI is secondary infection. Nope, never. UTI is a primary site of infection and cannot be considered secondary to another site. So let's see why. Positive urine culture on admission equals POA, as I said, is a no-no. on January 2nd, a positive urine culture during the POA timeframe without UTI signs or symptoms, nor a matching blood culture in the IWP is not an event. Therefore, this does not meet POA. Later down, we have a 1.9 positive culture. It sets our IWP from 1.6 to 1.12. We do have a fever on 1.10. Our DOE is 1.9. The catheter was in place for greater than 2 days on the date of event. Therefore, this meets SUTI 1A. CAUTI, which is HAI. Our third one is just the opposite. You think you've got UTI symptoms on admission? No. A urine criteria is not met. The POA requires a positive urine culture. 311, the urine culture sets the IWP at 3.8 through 3.14. We have a fever at 3.10. And this can be used because it occurs in the IWP set by that urine culture of 311. The DOE is 3.10. We cannot use the 3.1 fever greater than 38 because it did not occur in the IWP. So you will have problems from time to time, and you'll be sending questions to NHSN. So when you do send those questions, please give us the date of admission, when the catheter was inserted and removed, the age of the patient, the results of the urine cultures with the colony count, signs and symptoms, any results of any positive blood cultures. Include what you think it might be. Do not include confidential, personal, identifiable information. As Kathy said earlier, please don't send us names. We'll delete it and ask you to please resend. Take a look at the frequently asked questions. They are your friend because sometimes you'll find the answers there if you're not visiting here very often. You can visit here and see frequently answered questions for UTIs as well as analysis, your annual surveys, your locations, miscellaneous, and CDA. I have got 5 case studies here, and it looks like we're doing pretty good on time, so we probably will go through all of these. If not, I will stop and then answer questions. So this is going to, we'll start looking at these. Now, when you go through case studies, I would like for you to follow this pattern each time. You're going to determine the date of the urine culture. If you don't have a urine culture, there's no reason to start an investigation. So get your urine culture. From the date of the urine culture, set your IWP. Determine if all the elements are within the IWP. Determine when the DOE is, if the date of the first element occurs the first time in the IWP. If the DOE is POA time period, well, if yes, then it's POI. If it is after that third day, or on the third day or earlier, or later, sorry. If no, it's an HAI. And remember that POA time period is defined as the day of admission to an inpatient location, the 2 days before admission, and the calendar day after the admission. So just a clarification on that. And then determine if it's device associated. So that's how we will look at each one of these. You want to save this, especially if you're a newbie, you want that. So let's look at a patient less than 65 years of age. Our patient is 57 on February 2nd. They were admitted to ICU on February 3rd. He had a temp on the 3rd and the 4th. We got our urine culture collected and positive for greater than 100,000 coag negative staph. So I don't believe, this is not a pull everywhere, so stay cool. So the first question is, on 2.3, can the fever be used as an element in this age? Yes, it can. Remember, our patient is less than 65 years of age. What is the case determination? Now, this is a pull everywhere question. What is the correct determination of this case? And what I've done is I've lost my cursor. That's okay. There we go. All right, well, let's see. We still have answers coming in. This patient has a SUTI 1B. It's non-CAUTI. So let's take a look. What is the rationale? 2-5 positive urine culture sets the IWP to February 8th. The 2-3 fever is eligible in this patient because it's the first element within the IWP. The catheter was not in place for greater than 2 days in the inpatient location on the date of event. Therefore, this is a SUTI 1B, non-catheter-associated UTI, and the UTI, RIT, and SBAP is set. Okay, now we're going to look at a patient greater than 65 years of age. Almost the same scenario. On February 2nd, the patient is the age of 75 in ED. We have a catheter inserted. Admitted to ICU, we have temps on the 3rd and the 4th. The urine culture is collected for coag-negative staph. On 2/28, the catheter is removed and discharged home. So the 2-3 fever can be used as an element in this age patient. No, it cannot. Can the 2-4 fever be used as an element in this patient? No, it cannot. So what is the correct determination in this case? Give it a thought. This patient does not meet a UTI event. So let's map it out. 2-5 positive culture sets the IWP from 2-2 to 2-8. The 2-3 and 2 fevers cannot be used as an element in this age patient because the catheter was not in place in the patient on the date of event for greater than 2 days. There are no UTI elements within the IWP, so there is no event, no RIT is set. You cannot call this a SUTI 1B. You cannot call this, period. So consider other signs and symptoms. If they collected this culture, why? There's something that didn't get documented, and that would not be good. Okay, we're going to do a knowledge check on this one. Patient was admitted to a med-surg unit for influenza. They had a headache, they have body aches, they've got nausea. The urine culture was positive for greater than 100,000 ephasium and 20,000 for Pseudomonas aeruginosa. A blood culture was collected on the same day that grew Pseudomonas. The blood culture can be used to meet the ABUTI definition. True or false? So there's your poll everywhere. We got half and half going here. Okay, I'll put you out of your agony. It's false. Okay. So let's look at the rationale here. To use the blood as an element in the ABUTI, the blood organism must match the urine organism greater than 100,000 and occur within the IWP. That Pseudomonas organism was only 20,000. Therefore, the Pseudomonas in the blood cannot be used as an element for the ABUTI. There are no UTI signs and symptoms nor matching blood within the IWP of the urine culture with ephasium. Therefore, there is no UTI event and no RIT nor an SBAP is set. Investigate the positive blood sample as primary BSI used as an element at another site-specific infection. Okay, case 4. Okay, we've got a prolonged hospital stay. We have a catheter in place since 1:30. On 2/11, we have a positive wound culture of staph species and an Enterococcus faecalis. We have a urine culture of greater than 100,000 staph epidermidis, and we also have a blood culture that is staph epidermidis. 2 of 2 blood cultures drawn on separate occasions. We have hypotension, no fever greater than 38, and there are no other UTI signs. Knowledge check. So get your phones back out. Be ready. So, what is the correct determination in this case? Is it a SUTI 1A CAUTI? Is it a catheter-associated ABUTI? This patient does not meet anything, or is a primary LCBI 2? This patient meets an associated ABUTI. So let's look at the rationale. 214, positive urine culture sets the IWP at 211 through 217. We've got no UTI signs within the IWP. We do have a blood culture that's positive, but it's an LCIB, and it's an LCBI2. And so we have our date of event on 214. The catheter is in place for greater than 2 days on the date of event. So this meets a catheter-associated ABUTI, and the matching blood culture is secondary. It is secondary to that ABUTI infection with either chills or hypotension. Reportable if the location is in the reporting plan. Okay, this is your last one. We do have a knowledge check. We have a patient who was admitted with a catheter with a 100.3 temp, temperature of 100.7 on the 7th of January. On 1/8, we have 100.8. The Foley was discontinued. We have a temp 99.6 on the 10th. On the 11th, we have a urine culture that's greater than 100,000 for Proteus mirabilis, and E. coli that's about 50,000 CFUs. We have max temp on the 12th at 99.6, and then they are discharged to rehab. How do we categorize this? A SUTI 1A, a SUTI 1B, or no event? So, what do you think? All right. So let's see the rationale. Oh, yeah, this is in order. All right. Okay. So we've got I've lost my, there we go. It meets a SUTI 1A, catheter-associated UTI, with the date of event 1/8. Even though the positive urine culture occurred 2 days after the Foley catheter was removed, the 1/8 fever was the first element in that 7-day IWP, therefore is the date of event. On the date of event, the catheter was in place greater than 2 days. This meets the SUTI 1A, catheter-associated UTI, date of event 1/8, with their pathogen of Proteus mirabilis. So, what have we covered very quickly in this last hour as we reviewed the protocol, key concepts, and your common pitfalls? Remember, positive urine cultures or UTI symptoms on admission does not automatically meet POA. UTI is a primary site of infection and cannot be secondary to another site. Do not change your device association during the UTI RIT. We identified how to count catheter days and to determine infection association. Remember that the catheter counts on the day of insertion, and if the catheter is in place prior to admission, it begins with the date of admission to the first inpatient location. We discussed some updates to our protocol, key terms, and definitions. We reviewed the data collection form on the table of instructions. We made correct UTI determinations through some case studies. We reviewed fever and age and device association, and we reviewed a booty. So remember, you got homework. You got 2 things. Remember to take some time to look at each one of those pages for your particular surveillance needs and take some notes. And visit your microbiology department. Make friends with your microbiologist. So, whether you are a young whippersnapper ready to take on the world, or if you are sophisticated and well-seasoned IP, I hope that your week here will be an educational one. You'll make friends and you'll do a lot of networking. So we do have time for questions. Go.
So during the infection window, if you have 2 UAs, one that reflexed to culture and was positive, greater than 100,000, and the second one that was done hours later didn't reflex, but was a completely clean culture, is there any way to utilize that second specimen in the determination of the case?
Okay, so your first culture grew out multiple organisms.
No, just
No.
one.
It just grew out one organism.
Correct.
Okay. You would start with that one. You set your IWP. It's the first one you got. You got to go with that.
Okay. I knew the answer, but I had to
you got
ask.
it. You can ask. Yes.
Could you please reiterate for me and perhaps some others in the group the 65 and older criterion when you can't use the fever, what the other things are? Because I think that a catheter-associated UTI would knock out a couple of those criteria, if you know what I mean. It's like, for instance, frequency. You're not going to have frequency, right? So could you just reiterate what you said about the 65 and older population for me?
If the only thing you have is a fever and it's not catheter associated, first thing, if you're considering fever in someone greater than 65 years of age, is it catheter associated? That means they have to have that catheter in place for greater than 2 days. Then if you only have fever, what's your DOE? If your DOE isn't on catheter day 3 or after, you can't use that fever. You can, if you got frequency, use that if it's before your culture, say. Or it's always good to look for another symptom. But if you've got fever, then you've got to bring that age, and then you've got to count your days. How long was that Foley in place? And even though we're trying to get rid of the word Foley, it's hard to have it to break.
Hi, this is another question that I think I know the answer to. If you have a patient that comes in with a existing catheter, Foley catheter, and they have yeast growing, and then a few days later they have E. coli, you still can't call that present on admission because the first one didn't count because it was yeast. Is that correct? And is there any way around, or not around that, but I mean... But I do mean that.
What you have not given me any dates on when things were collected, when the symptoms happened. I can't set you a IWP. So it sounds like you're trying to give me a case.
Let's say, on day 1 of admission,
And
they had a Foley catheter in. They had it at home and were admitted with it. And on that same first day, they had a positive urine culture with yeast. And then... let's say 4 days later, 3 days later, whatever, down the road, so it's not present on admission. They have E. coli growing with 100,000. Physicians will say, well, that was present on admission. They had that yeast, but we can't use that as a basis for that. Is that right?
The first culture you can use is one that's acceptable. And if the one was 3 or 4 days down the road, that's the one that you're going to use. If it was only one organism, no more than 2, that's where you would set your IWP. You can't set an IWP on an unacceptable sample.
Yeah. Okay, thank you.
Bonnie, we have a couple questions from the web. Can a blood culture with the same pathogen set the date of event for the CAUTI? The blood culture was collected within the IWP prior to urine culture collection, and the first symptom was the day after the blood culture was collected, but before the urine culture collection.
Okay, so if we have
sounds-
an IWP set and we have a symptom within the IWP, even though we have a blood culture that's positive, if I understand this correctly, if you have a symptom within the IWP, you no longer have an ABUTI. What is an ABUTI? Asymptomatic bacteria. If you got a symptom, that means you're symptomatic with your UTI. Does that make sense?
Yep, makes sense to me. So they cannot use, in that instance, they cannot use the blood culture. The blood culture would be secondary if it's within the SPAP.
It would be secondary
And it
if it
matches.
met that matching organism in the urine that was greater than 100,000. They could use that as a secondary.
Second question. If a patient has been admitted to an inpatient unit, but due to bed being unavailable, the patient remains in the emergency department in a holding status, can the CAUTI be attributed to the inpatient unit if the patient is not physically there but is assigned to the unit?
We start counting inpatient days, Foley days, any device days on the day the patient is admitted to the room physically. They got to be in that room, and then your device days count. So the answer is no, you don't assign a CAUTI or a CLABSI to an outpatient unit because they're not bedded units. Looks like we might have another one.
Yes, could you please clarify the use of urine that comes from a nephrostomy or urostomy or a suprapubic catheter? I know it seemed you said to look at that urine.
You can use a urine that's obtained when someone has a nephrostomy. If that's where you obtain that urine from, you can use that culture from that fluid to set an IWP. If that person has a catheter and a nephrostomy, then it can be catheter-associated, depending on how long they've had that catheter in.
So they could have a culture with a nephrostomy and a catheter, and it comes from the nephrostomy, but you can count it as a CAUTI, even though it didn't come from
Correct.
the indwelling catheter.
It's the risk that you're looking at, and there's a risk when there's a device.
Oh, okay.
Can I add something to
Kathy's
that?
going to expound on that.
So if the patient's got an ascending urinary tract infection, you could certainly get a positive urine culture from the nephrostomy urine. We do have an exception. If you have a positive culture from the nephrostomy urine and a negative from the Foley urine, in that case, it's obviously not ascending, so you don't have to call that a CAUTI. But if you only have a positive from a nephrostomy urine and you have a catheter in place, you have to call that. Make sense? I mean, we don't know that it's not down in the bladder, right? How do we know?
Okay, one more
last
question.
Oh,
Hi, I'm sorry, just follow up to your statement. So does the Foley culture need to be within that infection window period of the nephrostomy culture?
Probably.
Okay.
I don't know that we've ever been asked that question, but yeah, a week later you do a culture and it's negative. Patient's been treated for their urinary tract infection.
Okay.
That doesn't make any sense.
okay. I have a question sent by my IP friend who is watching right now.
Is it a specific case?
No.
Okay.
No, the question is when you said no other causes, like let's say abdominal pain with no other recognized cause, does it have to be documented by the physician or can the IP determine that there was no other cause?
That could be documented by the nurse that's taking care of that patient, if that's in her notes or his notes. And abdominal pain, FYI, is not an acceptable symptom. It needs to be
suprapubic
lower.
pain, for example,
Yeah.
for UTI.
Yes, it needs to be lower, FYI.
Or low lower abdominal pain.
Yes, that would be good. Get it into the medical records.
So it has to be in the record.
Yes, it must be in the records. Okay, we're done. It's 12:15. All right, thank you very much.